Let's talk now about the effects of electroconvulsive therapy on memory. When you think about it, if it wasn't for memory issues, we'd likely recommend electroconvulsive therapy for a lot more depressed patients. And the primary concern patients would have about initiating a course of ECT is the effect on memory. We could talk about short-term effects on memory, such that even if there were no longer-term effects on memory from ECT, we would have to be circumspect about using ECT if for a period of several weeks people may suffer memory problems, even if they're temporary. This is the primary reason that when people are getting a course of ECT, I strongly recommend that they avoid driving at all. And patients who are college students or who are working full-time, etc., may have to take a leave of absence from school or from work in order to complete a course of ECT. Now, this is not universal, and there are patients who continue to be able to work during ECT. They typically wouldn't get much work done on the day of an ECT treatment, but they might do fine otherwise. We could talk about both memory problems specifically, or sort of more global cognitive problems in general, including things like attention, focus or distractibility problems, or just a feeling of mental dulling, because a person might not have discrete problems recalling things from the last few days, but they might still have difficulty working or difficulty driving because of attention problems. And so an analogy would be there's people who are taking narcotic medication post-operatively, or people who've had a few drinks of alcohol who might not complain of memory problems but still could have impaired focus or coordination, such that doing things that involve multitasking, including driving, could be more problematic for them. Then there's the issue of longer-term memory issues following a course of ECT, or loss of longer-term autobiographical memories from a period of time far in advance of having started the ECT course. Those two concerns, will I lose memories from before I had ECT that are important to me, whether it is events in your life or fund of knowledge issues, such as, let's say you're a doctor and you're worried, will I be able to remember the symptoms of different illnesses, or will I be able to remember the doses of different medications or contraindications for those medications? You can imagine that that might be a concern for that person. And that's different than the question of, would I be, if I continue to work as a doctor during the course of ECT, might I make some mistakes in prescribing a medication for a patient because of attention problems or short-term memory problems, like ordering the same medication twice because I forgot that I ordered it the first time. And that, in turn, would be different than the issue of after ECT. Even if I was left with only very limited memory problems from the time period surrounding when I got the ECT, moving forward from ECT, would I have problems laying down new memories, say 3, 4 weeks, 5 weeks, 6 weeks after the course of ECT had been completed? So that's what I'd like to address right now. And like I said, this is often a major focus of the discussion with the patient during the pre-ECT consultation. And in addition, it's the primary reason that there's been so much research looking at alternative ways to deliver the ECT stimulus using a bilateral lead placement versus a unilateral lead placement. And what it comes down to in that discussion is efficacy. Is one lead setting or energy setting going to be more efficacious than another, versus the risk of cognitive side effects? And the take-home message from this is that no lead placement has been shown to be more efficacious than a bilateral, and in particular a bitemporal lead placement. Studies that have been done using the non-dominant hemisphere or right unilateral lead placement, where both leads are placed over the right hemisphere, have been able to, in some studies, achieve equal efficacy with bilateral, but generally not better efficacy. And some studies, some earlier studies have suggested lower efficacy for unilateral. And in particular, if you're not giving as high a dose as is necessary with unilateral to achieve equal efficacy to bilateral lead placement. And so in proposing these different strategies to patients and choosing a strategy for that particular patient, we're often in a position of having to weigh considerations of side effects versus efficacy. So if we were to break down the types of memory problems you could see with the ECT course, typically ECT can be associated with a mild delirium during the course of treatment that clears once the course is concluded. And by mild, I mean a person might not have it at all, but that people may complain of just feeling a little foggy in their thinking, going into the kitchen to get something and then saying, what did I come in here for? A person might have some trouble just with words being on the tip of their tongue, or having trouble recalling a person's name. And it might be worse in particular right after a person's had a treatment. When a person wakes up immediately after a treatment in the recovery room, they typically will be confused. And this is why we have nursing staff there to help the patient wake up smoothly, to make sure that the patient is reoriented and to make sure the patient has a stable gait before they would head for home. And it's also the reason that we will not send people home on their own or just stick them in a cab to go home, but why a person has to be accompanied by a family member or friend that we sign them out to on the way home. And then in terms of the most common, specifically memory complaints that a person can get, we could break this down into anterograde amnesia. So this would be amnesia for events occurring right after a treatment, versus retrograde amnesia, which would be events occurring prior to the treatment. And the anterograde amnesia tends to be for only about an hour or so after a treatment. This would be where a patient has a conversation with you after ECT but before heading home, and later doesn't have a memory of having had that conversation. This could be likened to being very similar to what you might see with an alcoholic blackout, where because of the effects of intoxication on the brain, a person could be lucid, conversational, engaged, but the next day might have no memory of those events because alcohol disrupted the memory storage from basically the buffers in RAM to the hard drive of longer-term memory. And so similar to a person with an amnestic disorder, the person is lucid and engaged in the moment, but the memories haven't been consolidated. It's not necessarily an indication that brain damage has occurred, and this is something that patients can be reassured about, that just because they don't remember something that they discussed with their family in the car on the way home from a treatment is not necessarily an indication that the hard drive or the hardware has been damaged, any more than if you were typing in Microsoft Word and hitting save every 10 minutes, and 8 minutes into having been typing, there's a power failure, and everything that you were working on for the last 8 minutes has been lost. It doesn't mean your computer has been damaged, but that data that was in RAM that hadn't had an opportunity to be stored into the longer-term memory storage of the hard drive is lost because it hasn't been consolidated. Obviously, the consolidation of shorter-term to longer-term memory is an ongoing process that takes place over a period of days to weeks rather than just hitting save and having it happen instantly. And you could see, because of that, why there can be a gradient of vulnerability of memory, with the memories, especially both anterograde and retrograde, with the memories being closer in time to an ECT treatment being more vulnerable than longer-term memories, which have long been consolidated into the longer-term memory storage facility. Rarely you will see patients who report a permanent loss of retrograde, more distant autobiographical memories, or of anterograde, persisting difficulties laying down new memories even years after ECT. What has to be sorted out in cases like that is to what extent the patient is still depressed, either because they weren't an ECT responder or because they relapsed after the course of ECT, such that depression is now causing memory problems, even to an extent that could be called a pseudo-dementia or dementia of depression. Or if after the ECT course the person is still depressed and for that reason or because of other medical problems is on multiple medications that are causing memory problems, such as benzodiazepines, anticonvulsants, or simply significant polypharmacy. Or was this directly related to the ECT? And in particular, for example, a person who is getting ongoing maintenance ECT, if it can't be stretched out, say, to every 4 to 6 weeks, but they're needing maintenance ECT at an interval of, say, every 1 to 2 weeks, could that be contributing to ongoing memory problems? Studies that have involved autopsy of patients who have received multiple ECTs over the course of their lifetime have not shown evidence of brain damage due to ECT. It's complicated assessing these situations because we also know that there is the potential for brain changes that occur with long-term depression. And there's also evidence of brain changes that can occur with longer-term use of some medications, for example, long-term use of antipsychotic medication. We also know that there could be a difference between the brains of depressed patients who are referred for ECT and depressed patients who are not referred for ECT. And so, for example, if we were to go to a typical inpatient psychiatric unit and separate out those patients who, for whatever reason, severity of depression, medication refractoriness, medical issues that complicated the ability to treat them with medication such that they were referred for ECT, for whatever reason. If you compared the patients who were referred for ECT with aged matched depressed patients who were not referred for ECT, what we find on MRI scan is more subcortical white matter hyperintensities in those patients who were referred for ECT than in aged matched patients who were not referred for ECT. And this does raise questions as to either whether more severe and medication refractory depression caused those hyperintensities or whether the patient had these hyperintensities and that was responsible for the depression. And so, for example, we've moved from the older diagnosis of multi-infarct dementia to talking about vascular dementia, that there can be a gradient of severity of vascular disease, and you can see vascular dementia even in people who haven't had discrete episodes of, quote, stroke. And there has been a hypothesis called the vascular depression hypothesis, that people with longer-term, more subtle cerebrovascular disease, that could be a cause of depression. And you could imagine why, if a person has an anatomic substrate like that for their depression, why they might be more medication refractory and might ultimately have more cognitive problems with their depression and might have more problems with lethargy or fatigue or executive dysfunction, and why they might ultimately be referred for ECT. And it's not uncommon in the ECT population, especially among older patients, to see comorbidities like hypertension, hyperlipidemia, or diabetes, all risk factors for cerebrovascular disease. And it's not uncommon for them to have other evidence of vascular disease in other parts of the body. And so that's a complicating factor. When we look at specifically retrograde amnesia, we can also break that down into two types of memory. There's autobiographical memories and there's non-autobiographical or impersonal memory losses. And ECT produces deficits in both of those domains. What people tend to emphasize in discussing ECT is the loss of autobiographical memories, but arguably those memories may actually be more strongly consolidated because they involve direct personal experience compared to impersonal memory domains. And so, for example, if something important happened in my life last week, like an illness in my family, I'd be more likely to remember that than something that I watched on the evening news a week during that same period of time a week ago. I also could distinguish between autobiographical memories that involve more severe things or sort of more memorable things, more emotionally salient things than things that were less emotionally salient. And so I'd be more likely to recall the illness in my family last week than, say, what I ate for dinner on Thursday of last week, which would make sense. What we do know is that when people do have losses in both of these domains, those losses improve substantially after completion of an ECT course, but residual difficulties have been reported to persist in some patients. We also know that the severity and persistence of the loss is greater with a bitemporal stimulus electrode placement than with a right unilateral or non-dominant lead placement. And we also know that when you use a sine wave electrical stimulus, that you're more likely to have deficits than if you use a brief pulse or ultra brief pulse stimulation. And I'll talk later about what I mean by those different electrode stimulation parameters. We also know that the extent of amnesia when we do objective neuropsychological testing isn't significantly correlated with the degree of therapeutic improvement. So in other words, there are patients who show a very good antidepressant response to ECT, but also have complained of memory problems during the course of ECT or post-ECT. And there's also patients who have done poorly with the ECT who report this. Now, we'd want to try to sort out some things. If a patient wasn't responding well to ECT, did that patient receive more treatments than a person who responded rapidly to ECT? And also, toward the end of the ECT course, when they weren't responding well, did we ultimately try going up on the energy settings to see if a higher energy dosage would be more efficacious since they weren't responding to the lower dosage, especially as we're getting toward the end of the ECT course and before we write off ECT entirely, discontinue ECT and have it listed in that person's record that they have failed ECT so that there's no point trying it again. You know, would we discuss with the patient trying a higher energy setting toward the end of the course such that that person didn't respond well to ECT but then had more deficits because of the way the ECT was delivered rather than the absence of response of their depression? Now, that's looking at objective amnesia. If we look at subjective or self-rated problems with retrograde amnesia, especially loss of autobiographical memories, that does tend to be more highly correlated with the therapeutic outcome. In other words, people who didn't show as good a response to ECT or who are still depressed are more likely to subjectively report that they've had more memory problems for things that occurred before the ECT. And again, I'm distinguishing this from neuropsychological objective memory testing results. Now, that's not to mean that it's not relevant, that the person is subjectively having these. And one might argue maybe they're picking up on something that the psychological testing just hasn't been able to pick up on. So it doesn't invalidate it, but I'm just making that distinction here. Here's one study from a while ago by Lisenby et al. That tried to specifically parse out differences in retrograde amnesia for autobiographical events versus impersonal memory events, looking at unilateral versus bitemporal ECT. So this group took 55 patients with major depression and they randomly assigned them to either unilateral or bilateral treatment. And then within those two groups, randomized those to either a lower energy dosage or a higher energy dosage. And then they had a scale that they gave these patients, the personal and impersonal memory test, which was administered by raters who were blinded to which ECT setting they were getting. So these were not being assessed by the ECT doctor, but by some other rater. And they assessed these people during the week after the ECT course and also at 2 months of follow-up. So what they did was they were asking, and they also, of course, obviously gave it before the course of ECT. So what they were asking about was discrete events occurring within the past 4 years. And they had 5 categories of personal events and 5 categories of impersonal events. And the personal events were gifts given or received, illnesses in family members or friends, major purchases made, trips taken to places at least 50 miles away, and restaurants that the person had been to. The impersonal events were things that you might see on the news. Births and deaths of famous people, political changes, court cases or trials, natural and man-made disasters, and other major news stories. So in each category of these 10 categories, 5 personal, 5 impersonal, subjects were asked to recall as many unique events as possible for up to 20 events and to recall the month and year of each of these. And then for the most recent and the most remote events, they also were asked to give a very rich description of as many details as possible, right? And the recent events had all occurred within 3 months of the baseline assessments, and the remote events all occurred at least 3 years earlier. Now, what was the purpose of that? The idea here is, what if you can remember that you went on a vacation and when it occurred, but you just don't remember the details of the vacation? So they wanted a way to try to capture that as well. Now, memories can fade. We all know that memories can fade over time. And so what you really want is also to test normal controls at the same matched intervals to compare the ECT patients with the normal controls. Now, arguably, a better control group might have been depressed individuals who had not received ECT, who were being treated with medication, if we were really looking for separating out and controlling for those factors. But you could see the argument for using just a normal control group of non-depressed people compared to ECT. That tells us something somewhat different. So what did they find? 1 week after the course of ECT, the patients who had received ECT recalled fewer events and fewer details than the control subjects, and the deficits were more marked for the impersonal events compared to personal events, to autobiographical events, for the reasons that I mentioned, that probably personal events are just encoded that much more deeply and are more resistant to being lost. Further, the patients who had received the bilateral, bitemporal ECT placement had more marked amnesia for the events and the details of the events than the ones who had received unilateral ECT. And that was also especially true for the impersonal memories. And these effects were independent of the dosage, low versus high dose, or of the clinical outcome, improved from ECT versus not improved. Now, when they looked at them 2 months after ECT, when we looked at the personal events, the patients showed no change from baseline measures in their recall of those personal events. And they didn't differ from normal controls in this, but they did still have some decreased recall of impersonal events. And they found similar findings for event details. Shortly after the ECT, patients recalled fewer details about recent events relative to remote events. And again, the effect was greater for the details of the recent impersonal events than for recent personal events. 2 months after ECT, the only residual in memory for event details was among patients involving recent impersonal events. So again, this gradient where more recent memories are more vulnerable and where impersonal events are more vulnerable than personal events. But for both personal and impersonal events, the less salient events were the ones more readily forgotten. So again, something very important to you is less likely to be forgotten. And that's something worth discussing with patients. So how is this relevant to informed consent when you're having a pre-ECT discussion with a patient? What I like to go over with patients when I'm discussing ECT with them is that the memory of public events will be more disrupted than the memory of autobiographical events. That events closest in time to the administration of ECT seem to be the most vulnerable, that personal events of less objective salience are more likely to be forgotten than the higher salience events, and that amnesia for the details of events, i.e. the richness of memory, follows the same pattern as amnesia for the occurrence of events, and that bitemporal ECT may result in more profound and persistent impairment than right unilateral ECT, and the effects of ECT on memory of personal and public events are independent of therapeutic response. All right, so that is a basic overview of what we're concerned about in terms of memory problems with ECT. What we'll talk about in a subsequent talk is the relevance of this in terms of trying to figure out a lead placement, a dose of energy to give, and the frequency that you'll give ECT. In other words, twice a week versus 3 times a week, or maintenance treatments at once a week versus 2 or 3 weeks in between treatments. Thank you very much.